Welcome to OrthoNeuro's monthly educational webinar. My name is Heather Benjamin. I'm the marketing director at OrthoNeuro. Thank you for joining us for our webinar, Hip Pain, We Can Help. Tonight's speaker will be Dr. Mark Kolich, orthopedic surgeon at OrthoNeuro. Dr. Kolich is a board-eligible, fellowship-trained orthopedic surgeon specializing in outpatient total joints, minimally invasive anterior approach hip arthroplasty, less invasive total knee replacement, and complicated hip and knee revisions. Dr. Kolich will answer questions following his presentation. Please type your questions into the Q&A box at the bottom of your screen. Dr. Kolich?
Thank you very much, Heather. I appreciate it. So, thank everyone for listening in, and I'd be happy to take your questions at the end of this talk. So let's get started. Our topic is hip pain, we can help. So I'll go through the anatomy, treatment, and the surgical journey that you may undergo. Okay, so I provided a little bio about myself here with this first slide. So I'm an orthopedic surgeon. I'm fellowship trained in adult hip and knee reconstruction, and I'm practicing here in Columbus, Ohio at OrthoNeuro. My medical school training was at Ohio University, College of Osteopathic Medicine. I then did 5 years of training in Canton, Ohio at Altman Hospital. I was chief resident in 2020, followed by completing an adult hip and knee reconstruction fellowship within the last year here in Columbus, Ohio. So a little bit about my volume. So I've done over 2,000 hip and knee arthroplasty cases between residency and fellowship. So a total of 4,400 cases overall. So and specifically for this talk, I have specialized training in minimally invasive anterior approach total hips, as Heather just mentioned. So that's relevant to today's talk, and we'll talk a little bit about what that is, what that consists of, and the difference between anterior hip patients and some of the other approaches that you may have heard of or maybe have some questions about. So I've got some publications that are out there relevant to my field in hip and knee arthroplasty, between the Journal of Arthroplasty, Surgical Technology International, and also have a publication through New England Journal of Medicine. I also had the opportunity to present at a number of different meetings at the American Osteopathic Academy of Orthopedic Surgeons. I was able to have a presentation at the American Academy of Hip and Knee Surgeons for one of my articles that was published in the Journal of Arthroplasty, which is an academy meeting specifically just for our hip and knee colleagues. And then also had the academy meeting 2 years ago at the American Association of Hip and Knee Surgeons as well. Sorry, that's a duplicate there. That should be American Association of Orthopedic Surgeons. So disclosures for tonight's talk, I don't have anything that I need to disclose relevant to any specific implants or vendors. So on today's agenda, I'd like to, we had our welcome and introduction. So things that I want you to ask yourself when thinking about issues that you may be having, and we'll run through some of those. I'll talk about what joint arthritis is, some of the symptoms and prevalence of joint arthritis, as well as diagnosing hip arthritis. We'll go through some of the treatment options that are available today, as well as relevant anatomy. So understanding some of the anatomy helps patients understand what they may be experiencing as well. And then talk about when you should potentially consider surgery. And then that journey that we discussed of having a joint replacement and what that may look like for you. Questions and answers that I'd be happy to take at the end of today's presentation. So feel free to type in a question at the end, and we'll go through those. So have you experienced any of these problems within the last week, or really, over the last few months or years sometimes, but mostly with hip arthritis? Normally this can present itself relatively quickly as we're bearing all of our weight through our hip joint. So some of the issues that some patients may describe or you may be experiencing is difficulty getting out of bed, going up and down stairs, activities of daily living like housework or gardening, getting in and out of a car, going from a sitting to a standing position, potentially bending over to tie your shoes, difficulty with just placing one leg over another to cross your legs, or other activities of daily living like shopping may become difficult for patients that are beginning to have the early symptoms of hip or knee arthritis. So what is joint arthritis? So arthritis is inflammation of your joint that develops over time. This can make it hard to do everyday activities like I was just discussing. So there isn't a cure for joint arthritis at this point, but we'll go through some of the treatment options that can help alleviate the pain and help patients stay more active. So osteoarthritis, there's a number of different arthritic type wear patterns, but specifically osteoarthritis is the most common form of arthritis. It's degenerative. We often refer to it as the wear and tear type or the tattered and torn type of arthritis. This causes the cartilage or the shock absorber within your hip joint to gradually wear out. And then over time, that cartilage wears down to bone and results in bone-on-bone articulation through that hip joint and causes patients to have pain. So I provided a picture to the right here. If you look at the image on the left, you'll see that the hip joint has that smooth, shiny pink, glistening cartilage on the end of that hip bone there, similar to the way that the end of a chicken bone appears. And over time, what ends up happening is as we wear through that smooth, shiny, glistening cartilage, we have that worn cartilage that wears down to bone, which produces pain, which you can see in the arthritic hip joint in the picture to the right. So symptoms of joint arthritis. So most common symptoms are physical. We'll have chronic aches and pain. Sometimes you can have a feeling of heat or swelling in your hip joint. Often we'll see decreased mobility as a result with associated joint stiffness. You have difficulty going up and down stairs, getting in and out of chairs, or doing things at home like climbing out of the bathtub. A lot of times patients will come in with complaints of difficulty sleeping at night, and that can be a reason that tipping point that brings patients in to have their hip issue addressed, or see their primary care physician, who then refers a patient to their hip or knee surgeon. So, but they also can be psychological. So this can be very debilitating and discouraging. Having the decreased mobility and pain associated with hip arthritis. So you can have symptoms of depression. And sometimes, patients won't come in because of the fear of surgery. So the whole point of tonight's talk too is to try and alleviate some of that anxiety and make patients feel more comfortable with the idea of pursuing the non-surgical as well as surgical treatment options and some of the advances that we have today that really are exciting. Contributing factors can be due to age, weight, the patient's activity level. Some can be genetic, as well as the abnormal body structure is possible too. So we see some outliers that cause the accelerated wear and tear, as well as post-traumatic. So some folks can have some previous injuries that accelerated the wear in the hip joint. So you're not alone. So there's a lot of patients that are experiencing, or a lot of folks in general that are experiencing hip arthritis. So close to 3 in 10 adults that are over 18 have problems with their joints. So 21% have arthritis, 17% suffer from pain, stiffness, or loss of flexibility in their joints. There's 54 million adults that have diagnosed arthritis. So very common. So the most common cause of work disability is arthritis in the US. So, and then you'll see the numbers there, 700,000 knee replacements, over 325,000 hip replacements every year in the US. And this is a fantastic procedure for our patients out there. It's one of the biggest advances that we've had in modern medicine is the total hip arthroplasty. Diagnosing joint arthritis. So there's a number of things that we can do, some fancy tests that we're able to obtain to diagnose joint arthritis. But the most important by far, the first two at the top are the physical exam, the patient's history, of course, and x-rays. So some patients will come in with an MRI or CT or bone scan and some blood work. But by far, diagnosing joint arthritis is typically just with a simple plain x-ray, as well as the physical examination. It can be pretty straightforward in diagnosing hip arthritis. So the x-ray that I provided on the right of the screen there, you can see, so the patient's right hip, which would be the left side of our screen. I don't know if you can see my joint, this cursor here, but the ball is nice and round. And if you look at the socket side, you'll see some increased bone that's being laid down, which appears as a bright white, which is calcium that's being laid down from increased contact forces. Although you'll see that the patient still has a space between those two areas, and that is cartilage that we are not able to see on x-ray. So this patient likely has some early arthritis and likely would not have any symptoms on this right side, which is the patient's, the left side of this image here. And if we compare that to the opposite side, it becomes very apparent looking at this image that there is no joint space here. You would not be able to even slip a playing card through this space here, and the patient is bone on bone. This upper portion of the socket side is where we bear the majority of our weight. So that is the area that typically wears out first. And in this patient's case, would likely be having significant symptoms of left hip arthritis. So treatment options. So there's a number of different treatment options, and this is really important. I talk to my patients about doing everything that we possibly can through a non-surgical treatment regimen until those are no longer working for them, and it's impacting their quality of life and activities of daily living before ever considering any surgical options. So non-surgical. So it's important to have motion through our joints. The lubricant within the hip joint actually provides nutrients to the articular cartilage in the hip joint with motion. So motion is good. It's just the high impact motion that we want to avoid. So low impact exercise is excellent. Yoga, swimming are one of the more common things that I'll discuss with patients. Some patients talk to me about dietary supplements and alternative medicine. I tell them that if it's working well for them, continue to do so. Glucosamine and chondroitin, there's a number of studies that are mixed, but if it's working well for patients, I encourage them to continue doing that. It's not going to hurt anything. So with increased weight generally causes more force through our hip joint. So weight loss drastically improves the patient's feeling through that hip joint. There was a study that was out there that described a 10-pound weight loss provided a dramatic improvement in our patients' symptoms and overall pain scores. So weight loss is a huge thing that I'll discuss with patients and try and get them active and moving as best as I can. Physical therapy is an option for patients. As the joint wears, our bony anatomy limits some of our motion. And when our motion is limited, the soft tissues that are around the hip and our muscles become very tight. So it's very important to maintain flexibility. That way, after surgery, you don't have to kind of work through some of that soft tissue stiffness after your total hip replacement. So physical therapy is important to work on range of motion and flexibility before and after surgery. Prescription medication. So I'll often prescribe an anti-inflammatory as a part of a patient's regimen, especially early on. to evaluate their response and try and get them some pain relief and keep them moving. If it becomes a risk where the patient is concerned about stability or falls, the use of assistive devices is a good idea, and I'll often prescribe a walker or cane. But a lot of times if patients are getting to that point, more than likely we're leaning towards a more surgical option. Joint injections are an option for our patients as well if they have not taken or undergone that procedure. Generally, patients get excellent pain relief. Depending on their activity level and previous history of injections, it varies on the extent or length of time that the joint injection will work for a patient. So, and then we'll go through some of the surgical options between arthroscopy and joint replacement. So the anatomy of the hip. So the hip is a ball and socket joint. So the ball is the femoral head, and you'll see that at the top of the thigh bone or the femur. And it fits into a rounded socket or a cup-like cavity called the acetabulum, which sits inside the pelvis. So that I have that pictured on the right here to depict what that looks like. So the cartilage, like we talked about before, acts as a lubricating tissue and cushions the surface of the bones to help the ball rotate easily within the socket. So over time, as it becomes irregularly shaped or it starts to wear into that ball a little bit, that's when the ball does not rotate as easily and pain is generated from the hip joint. So true, and I'll talk to patients often about this, is as this starts to wear, generally patients start to complain primarily of groin pain symptoms rather than anything else. So if it's out to the side of their hip, normally we're dealing with more of a trochanteric bursitis type symptom. And sometimes we can see an irregular wear pattern where the ball wants to wear into the pelvis more than to the upper portion of the socket. And occasionally they'll have some posterior buttock pain symptoms instead of groin pain. So when you have a joint, pain, when should you consider hip surgery? So, overall, like I discussed before, this is something that generally we consider after all of our non-operative treatments are exhausted. And it's become a point where it's affecting your quality of life, activities of daily living. You're having more bad days and good days. This has been going on for some time. This is something that generally will be worse after exercise or weight-bearing activities, and starts to affect your sleeping. So overall, my cutoff for the most part is once it affects your quality of life, this is a shared decision-making, and most patients, for the most part, are telling me that they're ready for a joint replacement rather than me having to have that discussion. So this is something that I never really have to tell patients. They need to have a total hip done. They're looking for something to relieve them of the pain that they're having. So conservative treatment first, and then hip surgery is generally the option. So surgical treatment options. So arthroscopy. So arthroscopy is utilizing small incisions, and they'll insufflate the joint with some fluid and place a camera within the hip joint and do any buffering that essentially needs to be done. This is generally for cartilage-related injuries around the acetabulum, which is the socket side. This is generally not as commonly performed as total hip arthroplasty. So a very limited amount of patients are candidates for arthroscopy, and generally there are younger patients that have an acute injury to the cartilage or the shock absorber around the hip joint. Joint replacement is not for all patients overall, and there's certain candidates, and I'll talk about what would or would not exclude you from having the total hip for the most part, and most of it is optimization and trying to get patients in the best shape possible that they can prior to undergoing an elective hip procedure. So in hip replacement surgery, the damaged bone surfaces and cartilage are removed and replaced with implants. So it's intended to give you restored mobility and reduce painful bone-on-bone contact. So if you look at the picture that I provided to the right, the the diseased ball is essentially taken out of the hip. Then we then replace the socket side, okay, with a metal shell, and then inside of that metal shell is a plastic liner. And then the femur is addressed, or the thigh bone is addressed, where we put a metal pin down into the thigh bone and articulate the two components with ceramic ball. So that's essentially a total hip arthroplasty from an implant standpoint. So, and then I'll discuss with you outpatient surgery as an option for the appropriate candidates. So what are the goals of a new joint? So the goals of a new joint is to reduce pain, improve the patient's quality of life. You want to regain strength and mobility. And then, while generally successful, some patients do have some mild pain symptoms and varying level of restrictions. Not all patients are the same in terms of what they're requiring. Some patients, this is their first joint, and some are reduced, which is generally the only reason that they would have any activity restrictions. All of my anterior hip patients are bearing full weight the same day of surgery without any restrictions. So joint replacement success. So technology and designs are continually evolving and enhance preparation, surgical accuracy, and recovery. There's newer software that allows surgeries to be templated and planned prior to entering the operating theater. So with all of my cases, I plan out every total hip arthroplasty before I ever get to the operating room. So I'm able to take the x-rays that were taken in office and then superimpose the size of the implants that I feel are going to be best suited for that patient that day. So that way, while I'm in the OR, I'm able to have a plan, and generally with it's within one size overall, which is very reassuring, and it only improves patient outcomes and overall satisfaction scores. So there's been many advances in minimally invasive approaches in rapid recovery protocols allow patients to return home safely with less restrictions post-operatively. So I take pride in the majority of my training between residency and fellowship, and now into practice, predominantly performing a minimally invasive anterior approach. So this approach is also called the muscle sparing approach. We don't cut any muscle, we only divide muscle, and we're able to perform this procedure through a smaller incision at the front of the thigh. And with rapid recovery protocols, like I said, patients are standing up the day of surgery, putting all of their weight down with a walker. For the most part, patients have a walker for a week or two, cane for a week or two, and then they're good to go. So I have them start their physical therapy post-operative day number 1 after their surgery. We allow that first day for some rest, and then that next day, patients are up and moving around without any groin pain symptoms. So it's a fantastic approach, and really it's changed the game in my opinion. Patients are moving so much faster at this point. And most of the studies that compare the anterior approach from other approaches demonstrates that they're moving much quicker in that early phase. In that first 3 months, they're going back to living their life much sooner. So the anterior approach, like I was saying, allows for less pain, limping, muscle trauma, easier assessment of limb length, and implant position under x-ray. So these patients have a quicker recovery, decreased risk of hip dislocation compared to some of the other approaches that are out there. So there are risks with joint replacement surgery, similar to any other surgery that you may have. They are subject to wear and tear, just like real joints. So but the plastic that we're utilizing today, this newer polyethylene or plastic, has an incredibly low wear profile at 0.01 millimeter per year, which is very, very low. So wear is not a concern with the newer implants. The life of the implant will vary based on the patient's health, their weight, their overactivity level, and some of the other variables. So you should always discuss any risk that you may have with anesthesia, and discuss any concerns that you have with your joint surgeon. So, and I'll take you through some of the stages of joint replacement. the first one is health optimization planning. So this is an elective procedure, and we'll go through some of the health optimization key points that I want to focus on. We'll go through the day of surgery, what that'll look like, your hospital and surgical center stay, as well as what it looks like when you go home, what to expect there, and then your overall recovery. So physicians educate patients and families about arthritis, treatment options, joint health, and recovery through smart lifestyle choices. So this should always be done with your surgeon. But overall, this is a shared decision making. So the patient as well as the surgeon, need to be on board, as well as the caregivers. And everyone should be on the same page in order to make sure that we have the best possible outcome and improved quality of life overall. So before your surgery, so ask questions. So if you have them, I would ask, what approach are they using? What to expect in the perioperative period. And if you have any other questions about your hip in particular, then I definitely would encourage your surgeon to educate you on that, as well as doing your own research is always a good idea. So the other thing that I started doing too is I encourage patients that to tour the facility. If they're worried about having the joint replacement and the anxiety building up to having their procedure done, go and tour the facility. A lot of times just knowing where you need to go and seeing the facility, talking to some of the folks and knowing, the day of surgery, you're not feeling like you're rushing and you know what to expect. Take you through the pre-op, the PACU area, and where you'll be doing some of your rehab early on prior to discharge is a huge help. And patients tend to like that. So also before your surgery. So health optimization is a big thing. So you have to undergo pre-admission testing, which generally consists of an EKG and chest x-ray. And then they do some routine lab work as well. If you do have any cardiac history, generally at that time, they will want some cardiac clearance prior to undergoing an elective hip procedure. If any patient has any heart, liver, lungs, kidney problems, generally I address them at this time. If they have any issues with glucose control, this is very important. So generally we want their hemoglobin A1C, which is the blood sugar over a prolonged period of time, generally over 3 months. We want that less than 8. With weight loss, this is something that depending on where you're at and the approach that's being used, ideally you can get your weight down as much as possible prior to this elective procedure. Smoking cessation is very important. This decreases wound complications, and overall, especially a month before or a month after, generally is what I like to say. Although I would like you to quit smoking altogether if possible, to decrease any risk for deep joint infection. Blood pressure control is important for patients, especially intraoperatively. That helps us control some of the blood loss. And then making sure that you're working with your primary care physician on that is imperative. And then sometimes if weight loss is an issue, sometimes in working with a dietitian or potentially a bariatric surgeon is an option prior to your total hip arthroplasty. Planning out how things are going to be orchestrated, working with your surgeon on what to expect, what date you want to have your surgery performed, and then planning on who's going to help out or be around at home to navigate in that early postoperative phase. And then exercises that you'll need to perform before and after surgery. And generally my patients don't have any issue working with the physical therapists. On my end, they all have my protocols and are very aware of what I would expect based on the approach that I'm utilizing. So, and then your support team. So your support team is extremely important for your overall care. Normally, you need somebody at home to help you out in the first few days, that first week at home, just to get up and out, going to and from the bathroom and to make meals. but generally slow and steady wins this race, and is what I like to tell my patients. So as long as you're getting up to go to and from the bathroom at home with some help, you're going to do very, very well. So you need to allow some time to recover, which is the sticking point with that. So day of surgery, the process. So my patients, they come in early in the morning, they go through the workup with the anesthesia. They'll talk with the anesthesia team. Generally, they'll have a block, as well as discuss the case with me the morning of surgery. So come in early in the morning. Once we bring you back to the operating room, generally the procedure takes about an hour to an hour and a half or so. Once the procedure is done, you'll go to the PACU area, and then later on be taken to either a second phase 2 area where you'll get up with a walker with a nurse or a physical therapist. And generally my patients are going home the same day of surgery, 4 or 5 hours after the surgery is complete. So they're doing very well. And with these rapid recovery protocols, it's been amazing how well patients are doing with anterior hip procedures. So pain management. So I use a multimodal approach. So patients undergo a general anesthetic, so they'll be completely asleep. I utilize a spinal as well as an injection locally at the incision site. So this helps dramatically with pain, and the utilization of narcotics is not generally needed nearly as much with our pericapsular injection. And while you're in the hospital, you'll get IV pain medication temporarily and then sent home with a number of different pain medications. And I'm very clear on what medications I would like my patients to take and how to take them and in what order to take them in order to get pain relief with minimizing narcotic use as well. And like I said, my patients get up out of bed the day of surgery. And then the family, generally is waiting, and I'll call them even before the patient's up and discuss the surgery with them and review the case with them and reassure them. Communication is important. So between the surgeon and the patient, the surgeon and the family is I think one of the most important things that sometimes falls through. And I think it's important to have a good relationship with your surgeon to make sure that that's not the case. And this is something that I take pride in doing. Recovery. Make it home, make it your goal to recover at home. So generally, patients, there's been a huge shift in how patients are treated and sent as an outpatient basis for hip and knee arthroplasty. So patients are no longer being treated like sick patients that have hip or knee arthritis, which is appropriate. So they shouldn't be in the same hospital as the patients that are ill with other sicknesses while you're recovering from a total hip or total knee procedure. So, and normally, most of the time, what keeps patients from going home is fear, fear that they're going to have pain, or fear that they're not going to have the adequate help. So having adequate help is very important, and I make sure I discuss this with all my patients to make sure that there is going to be somebody that's there and available to them. I call all of my patients on postoperative day 1 to check on them and ensure that everything is going smoothly and answer any questions that they may have. I give them my phone number for with my direct line for phone calls. So, and honestly, just having patients having that has really, we haven't seen a huge spike in phone calls because they know they can talk with me if they need to. And overall, that fear of having pain at home, I'm sending all of my patients home with the same medications that they would be getting in the hospital, and it's spelled out very clearly on what to take. And for the most part, patients get much better care and sleep at home overall with having family members to wait on them. And and not all the other noises and things that occur within the hospital system. So your support system is important. Recovery, like I said, the medications, at least on my end, are very clear on what to take and how to take them. And, it's very patient specific on what I want to prescribe for each patient. So as for activities in the recovery phase, so my patients are able to, like I said, bear weight fully on that operative limb the day of surgery, putting all their weight down with the walker. And they essentially have no restrictions. The anterior hip replacement is an extremely stable hip that would be very difficult to dislocate. So not the same restrictions that you typically would find with the posterior hip approach that you may have heard of previously, or issues getting up out of a chair or off of the toilet, where you would have that same risk of dislocation with the posterior approach. Diet, generally I have patients undergo a clear liquid diet and slowly advance that. Sometimes the anesthetic itself and the surgery itself, it's easier to tolerate a diet that advances from a clear to a solid food diet first couple of days after surgery. So, and then it's important to rest. And like I said, recovering at home a lot of times can help with that. So we allow our patients to rest that first day, and then of surgery, the day of surgery, and then have them start the physical therapy back at home. So for more information, reach out to your primary care physician or orthopedic surgeon, and then you can look for online resources at orthoneuro.com, or you can call OrthoNeuro at 614-890-6555 for an appointment. Thank you very much.
Thank you, Dr. Kolich. We have a few questions.
Yeah, absolutely.
So the first one is, can arthritis be prevented or cured?
So arthritis cannot be cured at this point. So that's something that, maybe in my lifetime is a possibility down the road, but we're not there yet. So I would say the progression can be slowed, but the overall avoidance of it, once the writing is on the wall, it's mostly trying to do those things that I talked about with low impact exercises, and then some of those other modalities that I can incorporate or offer my patients that may decrease some of their symptoms.
The next question is, what is the average life of implants?
The average life. So that's a difficult question, and that's a question I get asked often, actually. So pre-2004, before we had the plastic or the polyethylene that we utilize in total hips today, that plastic did not wear the same as the plastic does today. So the plastic today is better. And like I said, it's 0.01 millimeters per year. And with all of my hips, the majority of plastic liners that I'm putting in are close to 6 millimeters in size. So you'd have, over 100 years of potential wear and tear of that plastic liner.
When might a surgeon choose posterior approach?
So, I'd say this: the best surgery for a patient that has an orthopedic surgeon that they're going with is the approach that they're comfortable with. So the posterior approach is probably the most commonly utilized approach in the U.S., I would say. But there is a huge shift over the last 10 to 15 years of surgeons that are now adopting to utilize the anterior approach. With the posterior approach, you do have significant hip precautions, and the dislocation rate is higher than an anterior approach. But in a surgeon's hands, it's very comfortable with the posterior approach. It's still a great procedure. But, like I said, I think that the majority of surgeons that have the training would try and utilize an anterior approach for a lot of patients due to the rapid recovery and how well they're doing. So, and the thing is that there's no wrong approach, with each surgeon. It's just, I would recommend they do whatever they're comfortable with. And normally the anterior approach has a learning curve of about 50 cases before a surgeon's very or more comfortable, I should say, and have less complication rates. So, there's that fear factor for some surgeons that haven't done the anterior approach on adopting that new technique.
Thank you.
Yeah.
What did you mean by joint replacement isn't for everyone?
So, some patients don't have bone-on-bone arthritis. Some patients are not optimal surgical candidates. So some of those things that I talked about with patients needing to be optimized, sometimes patients have so many risk factors before they enter an elective procedure that it's the risk is not worth the reward of undergoing a joint procedure until they're optimized. So, and the most common one, that we refer to, are patients that have, a smoke, are active heavy smokers or have uncontrolled diabetes, or their BMI is very, very high. With an elevated BMI above 50, the complication rate can get somewhere upwards of 1 in 5. When normally, the rate would be drastically different than that without those other risk factors. So most of the time, it's those patients aren't ready for surgery, and it's more about optimizing them to make them better candidates for surgery in the future.
Is posterior approach the same as a total hip replacement and the anterior approach the same as the joint replacement? I'm confused on the terms.
They're both, so a posterior approach and an anterior approach are ways of entering the hip to perform a total hip replacement. So they both accomplish the same thing, but they're just a different way of entering the hip joint. So an approach, they go through the front of the hip to get to do the surgery. Posterior approach, patients will have a surgery where the surgeon performs the incision through the back of the buttock and go through the hip joint to perform the total hip replacement.
Can I have both hips replaced at the same time?
So that's a good question. So there are studies that are out there on patients that have bilateral or both hips replaced at the same time. When we looked at those studies where both were replaced at the same time, the patients have a more difficult recovery oftentimes with increased risks. So we've gotten away from replacing both hips at the same time due to those risks. And the risks are very real. They're risks for blood clots to the lung potentially, and infection are higher when we do both at the same time. So generally I tell my patients that I'll stage them 6 to 8 weeks apart, so you have enough time to recover from one, and then have the other one performed within that 2-month time frame. And recovering from a total hip procedure is drastically different. If anyone that's out there had a total knee replacement done, overall the pain is not nearly the same as a total knee replacement. My total hip replacement patients are very happy and generally describe a very different experience after having their hip done.
Well, that was the next question. How painful is the surgery?
So how painful is the surgery? So, I've never had a total hip done, but, I will say that, the patients that I've performed these on, through the front or an anterior approach, for the most part, they're very happy with it. And most patients had more pain prior to their surgery than they do after. So that groin pain is gone. And for the most part, they just have some incisional pain. around the incision site. But like I said, I use a numbing medication around the hip joint. So normally your hip feels very, very good for a while until, you can get over and get some of those pain medications that I talked about on board and undergo your rehab. But, overall, they're very successful, and hip surgery is not nearly as painful that some may tell you if you talk to anyone that's had a total knee replacement.
When will I know that I need to have surgery?
So, in most of the time, I have this discussion with patients that you'll know when you need to have it done, and you'll come to me for the most part. So, when you're having more bad days than good days, and it's affecting your quality of life and activities of daily living to the point that it's affecting all of those things that you're doing, then generally that's the time. I help patients make that decision. I never tell them that they need surgery, but when they're going through the things that they're able or unable to do at home, generally the answer is pretty clear on when they need to undergo hip surgery.
Can I go home after surgery if I live alone?
So that's one of the things that I don't send patients home if they live alone. So that would be one of the indications to having you stay in the hospital just for potential placement to either a skilled nursing facility or send you home with home health care. That way you have some help when you do go home. Because like I said, in that first week or so, that's really the only time you need to have somebody around to complete some of the activities of daily living, help you get to and from the bathroom, make sure you're safe, and help you make meals.
I need both my knee and hip replaced. Which should I have done first?
So I get this question a lot too. So for the most part, what I'd say is that if both are to the level where they need to be addressed, I do the hip first. And the reason is that I've seen where a hip is causing referred pain to the knee, which is not uncommon. So a lot of times patients that have significant hip pain or hip arthritis have significant knee pain on that same side. And I've had it where I've replaced hip and their knee pain went away. So generally I do the hip replacement first and then see them back in the office and get a feel for how their knee is doing at that time.
Which approach is better, anterior or posterior?
So I wouldn't say that any approach is better. So I think that the best approach, like I was saying, is the approach that a surgeon is most comfortable with, and that's the best approach. So and if you're dealing with a surgeon that's done a number of them from that approach, generally decreases risk for any dislocation or any complications as well. For me, personally, doing as many as I have through the anterior approach, I would lean on the anterior approach, but no approach is better than the other.
Will I be able to golf after recovery?
Yes. So all my patients, I want them to resume all activities that they were doing before. So I don't have any restrictions for my patients. So I want them to go back to living the life that they were living. That's the entire goal of undergoing a total hip arthroplasty. So I don't have any restrictions for them going forward. And normally I tell them that the ingrowth happens on the implant. The bone will grow into the implant normally at that 6 to 8 week mark. So normally after 8 weeks, I tell them they can go back to golfing.
Are there any restrictions with anterior hip immediately, like with the posterior hip?
No. So, I mean, I don't have any restrictions for my patients. That's saying that this is, a primary hip, that was not a redo or, anything else, that needed to be addressed at the time. But generally speaking, my anterior hips don't have any restrictions on the floor, and therapy. The physical therapy team is well aware of any patients that I were to do that weren't through the front as there would be some restrictions there.
We have one more. What offices do you treat at?
So currently, every week I'm in office in Grove City, as well as the office in Grandview on Olentangy River Road, as well as in Westerville. So I'm currently at 3 offices, and I'm there every week. And then there are some weeks that I will fill in some of the other offices to provide care and see patients as well.
Are there any additional questions? What does a consult appointment with you look like?
Yeah, so absolutely. So, normally, when I see patients in the office for the first time, I want to make sure that I do have some imaging to go off of. But generally speaking, I want to get a thorough history. So, like I said, the most important things on assessing hip arthritis for a patient is talking to them about their history, things that they've done before for their hip, what worked, what didn't work. Go over their x-rays with them generally and kind of tell them what I'm seeing, and then give my recommendations, based on those symptoms. So, and I'll see patients, where it's not necessarily their hip, but that's for me to figure out at that time point, and then make sure that they get into the proper hands if it isn't, and if it is, then I'm happy to follow them and work through with them and make sure that we get their quality of life back to where it should be, because ultimately that's what we're trying to achieve, and whether that's with any of the non-surgical options, whether it's physical therapy, anti-inflammatories, potentially any injection, or surgical options. So, and if it's nothing, if they just want education or they want to talk to me about their hip or what they're experiencing, I'm happy to do that as well. So, or if it's a second opinion, I'm happy to see patients just to give my input on what may have been recommended, and then what I see as well.
What is the total cost of a hip replacement as long as one has good insurance? Is most of the cost covered?
You know what, I don't have the answer to that. I would say that I know that with a hip replacement, generally speaking, that your deductible is met after a hip replacement. So if there are a left and right hip that needs to be done, or multiple joints that need to be done in the same year, I work with the patient to see if I can try and stage them within the same calendar year to help make sure that they're not getting hit twice for their deductible.
Any additional questions? Thank you very much, Dr. Kolich.
Thank you very much. And I appreciate everyone and all the great questions that they had. So, but like I said, if you have any questions at all, or you want to schedule an appointment, please feel free to call OrthoNeuro, and I'd be happy to see you.
Thank you. Thank you for participating in tonight's webinar. Our next webinar will be on November 3rd at 7 p.m. Dr. Shet Gary, OrthoNeuro's newest neurosurgeon, will be speaking on back pain. Check out our social media channels for additional information. Thank you and good night.
Thank you.
Thank you.